She's supposed to have she watch TV. It's not right. Shop these stores and if you are dealing with depression or anxiety, finding therapy can be overwhelming. Let go therapy help. We can make it easy. Just tell us your insurance. We find you great therapist covered by insurance available for you. We handle the part disease. And the best part, that session is only $21 with insurance. Find your therapist today at phonetherapy.com. I'm Jonathan, here to tell you about life insurance through the Colonial Dental. If you're age 50 to 85 and looking to buy life insurance on a fixed budget, remember the 3 P's. The 3 what? 3 P's. What are the 3 P's? The 3 P's of life insurance on a fixed budget are price, price, and price. A price you can afford, a price that can't increase, and a price that fits your budget. I'm 50. If you're age 50 to 85, call now. Top life insurance plan. Available through the Colonial. Options start at $9.95 a month. It's less than 35 cents a day. You cannot be turned down because of that. No medical opinion, no health questions. Your acceptance is guaranteed. And this plan has a guaranteed lifetime rate. So your rate can never go up. Options start at $9.95 a month. Plus, you get a 30-day money-back guarantee. So call now for information, and you'll also get this free beneficiary. Use this valuable guide to for your important information and get proper direction to your loved ones with your finances. And it's yours free, just for calling. So call now for information. Call 1-800-524-77. For information and free gift. That's 1-800-524-77. There's no risk or obligation. 1-800-524-77. Call now. New, sweet, and smoky McDonald's sauce. Very perfectly with your snack wrap. It's like spiking chicken gold. Special edition. Gold snack wrap. Wait. The night you graduated from law school. Michael, Rome. Mariani's. Okay, okay, okay. I'm gonna forget this. You don't forget that. I called the people here and decided to stop. Yeah. Fine, right. But none of the children saw you come down, but today, no. I knew today was feeding as soon as they started. Well, I just grabbed the cleaning pizza with black olives and chili, then salt. Them to walking up to the front of the house and came in and you just did off. God is the genius, and I am the genius because of marriage. You go. And he was going to give me a ride home in his car, but he can't because your car is blocking his car and drive. Oh, that's not there. Just give me a gift to my car. Well, we already tried that. Sounded like for the extra key. We tried to start it up and nothing happened. You might you push it into a parking space and might have my mechanic will get it too. Your mechanic works on Sunday? That's right. We're in that car right now. I'm really sorry about this. Oh, so this is where the anchovy black olive sausage pizza went. You mind if I?
Get inside the car, quickly! Good morning, good morning, good morning, good morning. It is now 8 o'clock and it is time for us to have our CME this morning. I am so excited because of the topics that we are bringing to you today. But before we get started, let's begin in a word of prayer like we usually do. Father God in heaven, we come before you this morning, thanking you so much for allowing us to see this day. We thank you for all of your mercies. We thank you for your goodness. We thank you for your kindness. We thank you for a wonderful opportunity to learn and share with each other. We pray that you open up our minds, that we would be receptive to the knowledge that we will receive. We thank you. We praise you. Be with the presenters today as they impart knowledge unto us. This I pray in Jesus' name, amen. Okay, so this morning we are going to have a clinical pathological case brought to you by the Department of Accident and Emergency. I get so excited for these type sessions because it brings to life things that we see on a daily basis, and it gives us an opportunity to share with each other so that we can review management and we can update our knowledge and be better prepared to deal with another similar case. So at this time, I am going to invite the Department of Accident and Emergency to present their case.
So good morning, everyone. It is indeed a pleasure and a privilege to be here this morning with you to present to Clinical Pathological Conference representing the Emergency Department. I am Dr. Davis. With me, I have Dr. Delancey and I have Dr. Joseph. And with that, I'm going to turn it over to Dr. Delancey.
Good morning. I'm pleased to present at the Clinical Pathological Conference today. My name is Dr. Delancey. And I will be presenting on appendicitis in the ED, improving our time to definitive diagnosis. I am a senior registrar at the Accident and Emergency Department. And here we go. I have no disclosures at this time. So we're going to begin with a case history. So a 21-year-old male with no past medical history presented to the emergency room with a 4-day history of epigastric pain, which migrated down to his right lower quadrant. It was associated with multiple episodes of non-bloody, non-bilious vomiting, as well as watery diarrhea. He denied having any fever, chills, or any urinary symptoms. Vital signs on presentation were stable, apart from him having a temperature of 99.4 degrees Fahrenheit. Physical examination was unremarkable, except for on abdominal examination, it was soft but tender in the right lower quadrant. Rebound and guarding were present, but no masses or organomegaly were palpated, and it was negative for any McBurney's point tenderness. So labs were taken off for CBC with differential, Chem 14, CRP, ESR, as well as urine was collected for urinalysis with microscopy. The patient was given morphine 7 milligrams IV stat, along with metoclopramide 10 milligrams IV stat, and a bolus of fluids was started as well. So when the laboratory investigations came back, it was notable for an elevated white blood cell count of 16.5 with bands of 21%, neutrophils of 75. The chemistry was within normal limits, and urinalysis showed trace occult blood, 15 ketones, and negative for nitrates or leukocyte esterase. So ultrasound was done. The ultrasound of his right lower quadrant stated that the appendix was not visualized, but there was minimal regional free fluid, normal bowel loop peristalsis, and no free fluid in Morrison's pouch. At this time, his Alvarado score was calculated. It came back at 9. His air score was also calculated because his CRP was elevated at 25. So it gave him an air score of 8. So at this time, he was then referred to the surgical registrar and SHO on call. This was about 7 hours after original presentation to the hospital. Surgical team at this point did not feel that the patient had an acute abdomen. They thought he may have kidney stones. So they requested a CT abdomen prior to any further interventions. The case was discussed with radiology, who agreed to do the CT abdomen. However, they wanted the patient to have IV and oral contrast. Unfortunately, due to technical difficulties, it took the patient another 7 hours before he was able to have the CT abdomen. The CT abdomen at that time showed findings suggestive of acute appendicitis with significant intra-abdominal free fluid. A small subhepatic non-dependent air pocket was noted. Perforation of the appendix was not excluded. And of note, the patient did have bilateral non-obstructing renal calculi, small, less than 2 millimeters. So at that time, the patient was re-referred back to the surgical team that we had spoken with earlier, and they decided that they would urgently take the patient to the OT. Inside OT, it was found that the patient had a gangrenous appendix that had ruptured, and there was significant pus in the intraperitoneal cavity. The appendix was removed, and the peritoneal cavity was extensively irrigated and suctioned. The patient's abdomen was closed, and the patient was sent to the ward. So patient was continued on ceftriaxone 1 gram IV and metronidazole 500 milligrams IV Q8 hourly. He had 1 temperature spike in the hospital on post-op day 1 with a temperature of 101.4 degrees Fahrenheit. Post-op day 1, they repeated the CBC. It showed a normal white blood cell count of 8.4, but the bands had increased to 27. Post-op day 2, a repeat CBC was done again, and white blood cell count remained within normal limits, 7.5. And at this time, there were no band neutrophils noted. So the patient was discharged home on post-op day 3 and had follow-up at 1 week and 3 weeks post-op, which showed no complications at that time. So moving on, we're going to talk a little bit about appendicitis. Acute appendicitis is, as we all should know, an inflammation of the appendix. It's usually a surgical emergency, and it's also one of the more common causes of acute abdominal pain in the emergency room. Approximately 8.6% of men and approximately 6.7% of women with right lower quadrant pain will ultimately be diagnosed with acute appendicitis. The peak age of acute appendicitis is between 10 and 30 years, as was seen with our next patient. So we should be aware that there are a number of clinical signs that can clue us in towards the diagnosis of appendicitis, such as migration of the pain down to the right iliac fossa, any right lower quadrant pain, any nausea or vomiting, any rebound on palpation, any signs associated would be any elevated temperature or leukocytosis or white blood cells shift to the left, Robson sign, and or local guarding. So this table is actually showing you that there was a study done by Kinesia et al. In which they did a meta-analysis of 32 studies, and they looked at the accuracy, the sensitivity, and specificity of the various signs, symptoms, and laboratory investigations used to diagnose appendicitis. And they found that the most sensitive finding was right lower quadrant pain or tenderness, and this is helpful in ruling in the diagnosis of appendicitis. And the most specific signs were temperature, an elevated temperature, as well as rebound pain. And although a lot of people say appendicitis is unlikely when the white blood cell count is normal, unlikely is not a reassuring enough thing for most physicians. And while we can see that browsing sign and local guarding both seem to have high specificity, their sensitivity is low and can only really be used more so to rule in the diagnosis as opposed to ruling it out. So although acute appendicitis is actually supposed to be more of a clinical diagnosis, it remains a challenge to diagnose as the clinical presentation varies a lot. So the diagnostic sequence of the colicky, abdominal pain, central abdominal pain, followed by vomiting and migration of the pain to the right iliac fossa is only present in about 50% of the patients that present to the ER. So in this retrospective study done by Leung et al. In 2017, he assessed the accuracy of emergency physicians to detect acute appendicitis based on a clinical examination alone. And he found that the sensitivity was 81% and the specificity was 84%. And so overall diagnostic accuracy was 84%. And so basically he concluded that we get a lower accuracy based on physical examination alone, as opposed to the accuracy that would be obtained when we get a CT scan for these patients. So with this being said, they decided that they would come up with risk stratification or scoring systems that could help to decide better or to better guide decision-making in order to reduce admissions, optimize the utility of our diagnostic imaging, and prevent negative surgical exploration. So the first and oldest scoring system developed was the Alvarado score. And the Alvarado score is actually divided into 3 categories. And if you get a score, they have 3 symptoms, 3 signs, and 2 laboratory investigations. And if you get a score of 1 to 4, then or 0 to 4, it's low risk. If you get 5 to 6, it's moderate risk, and 7 to 10 would be high risk. As we can see, our patient had a Alvarado score of 9, which would have put him in a high risk category, which means that he would have needed further investigations in order for us to determine what to do with him at that time. And so the AIR score uses very similar categories to the Alvarado score, and with the exception that they include the CRP. And they found that AIR scores greater than 8 has greater sensitivity and specificity for diagnosing acute appendicitis. So this is just a prospective comparative study that was done by Deepak et al. And in this, he had 100 patients who presented with right lower quadrant pain, and he calculated both the AIR score and their Alvarado score and tried to determine which one was actually better at determining acute appendicitis. And so what he did was he used cutoff points. So he said greater than 4 points, how does the AIR score compare to Alvarado? And greater than 8 points, how does the AIR score compare to the Alvarado? And so he found that the AIR score had greater sensitivity and specificity at a cutoff of greater than 4 points versus a cutoff of greater than 8 points. And the diagnostic accuracy for the AIR score was greater than the diagnostic accuracy for the Alvarado score. And so basically his study is kind of supporting the use of the AIR score versus using Alvarado score in order to diagnose appendicitis at this time. And this is just a pictorial representation of the findings that he found on the chart, showing the area under the curve. And so the greater the area under the curve, the better the sensitivity and specificity. And so as you can see, the green line is actually the air score and the blue line is the Alvarado. And so the air score can diagnose appendicitis better than Alvarado score can. So looking at the air score, in low-risk patients, this was a prospective interventional study done by Anderson et al. That demonstrated that in low-risk patients, the air score resulted in less imaging, fewer admissions, fewer negative explorations, and fewer operations for non-perforated appendicitis. And in high-risk patients, it only provided less imaging. No other differences were found for those patients. And then for intermediate risk patients, the air score did not provide any difference in the negative appendectomies. And it did not really produce much of a difference in terms of diagnosing patients with appendicitis. And it was kind of similar for patients having surgery for non-perforated appendicitis. And so the air score is best used in low-risk patients. So moving on to imaging to diagnose appendicitis. Basically, imaging is imperative to reduce our negative appendectomy rates and to reduce the rate of misdiagnosis. As we saw earlier, clinical examination alone can miss up to 15 to 25% of appendicitis. So it's important to utilize our imaging to assist with accurate diagnosis. Now, abdominal x-rays really should play no role in diagnosing appendicitis. However, a lot of times at Princess Margaret Hospital, the radiologists like for us to start with an x-ray prior to obtaining an ultrasound or a CT scan. And since PMH has no official policy with regards to which imaging study should be done, this kind of leads to a delay in appropriate diagnosis of appendicitis. Delays are also caused by inadequate knowledge of imaging guidelines, inappropriate use, like I said, of abdominal x-rays, use of oral contrast for CT scans, as well as concern for any contrast-induced kidney injuries. So there are a few modalities that we can use. The graded compression ultrasound is the first-line imaging modality recommended by the American College of Radiology for pediatric patients, as well as pregnant patients that are suspected of having appendicitis. As we can see, the sensitivity is on the lower side compared to CT scans with only 75 to 90%. And contrast enhanced CT scans are actually considered the gold standard, and they have a higher sensitivity and specificity. MRI of the abdomen is very sensitive as well as specific. However, lack of access to it, as well as the time that it takes to perform a study, limit how often we use this to diagnose appendicitis. And this slide just shows that the advantages and disadvantages of ultrasound. As we know, ultrasound is operator dependent, less sensitive and specific than CT scan or MRI. However, CT scan will expose the patient to radiation. It does take longer than an ultrasound and is more expensive and cannot be used in pregnant patients. MRI, of course, is the most expensive, but it's slower and not as readily available. So in this study was done because despite the overwhelming consensus that CT scan should be first-line imaging, there's still a lot of controversy over whether or not patients should receive oral versus IV contrast or both. So in a Cochrane review of 64 prospective studies done with 10,000 plus patients, Rudd et al. Compared the results of the CT scans of the abdomen and pelvic against reference standards like your operative finding or your pathology report. And basically, they found that any type of CT, the overall sensitivity and specificity was good. Unenhanced CT scans was a little bit lower, but still above 90%. And CT scans with IV had great sensitivity and specificity. And then CT scans with oral, the sensitivity, oral contrast alone, the sensitivity decreased a little bit. Both oral and IV had excellent sensitivity and specificity. So with that being said, is oral contrast for CT scan absolutely necessary? So not really. And based on the studies that we saw before, and the disadvantages of using oral contrast is that it increases your time to definitive diagnosis. It increases your risk for aspiration should you need surgery. It may increase the need for invasive procedures. It prolongs the ED length of stay, and it increases the time that the patient takes to get to surgery. So one study using oral contrast with CT abdomen was done, a retrospective review by Sadat et al. And they found that, as we stated just now, the average time from ER to OT increased in those patients with contrast. Their average length of stay increased because a lot of them tended to develop a pneumonia. And then some of them also developed ARDS as well. So some of the complications that may arise from a delayed diagnosis of appendicitis would be a gangrenous appendix like our index patient, perforation of the appendix, and/or abscess formation. And so the morbidity and mortality, of course, is going to increase if the diagnosis is delayed. If there is no gangrene, you have a mortality risk of 0.1%. With gangrene, 0.6%, and with perforation, your mortality risk increases to 5%. So, in summary, clinical examinations alone should not be used to definitively diagnose appendicitis. Use of the AIR score in low risk can expedite discharge home, reduce unnecessary imaging in intermediate and high-risk patients. Ultrasound is best used as a rule-in diagnostic test when you have positive findings, but cannot rule out appendicitis if unequivocal or negative. CT abdomen is still considered first line in non-pregnant patients. Non-contrast CT abdomen should be considered due to its comparable sensitivity and specificity with CT abdomen with IV contrast. And the use of IV contrast alone for CT abdomen will help improve patient throughput in the ED. These are my references. And thank you very much. Dr. Joseph is going to come and present. We'll have questions at the end.
Good morning, everyone. I have no disclosures. We will start with a case of a 49-year-old male HS who presented to hospital via EMS after being involved in a road traffic accident. Unrestrained, he rear-ended another vehicle. He presented complaining that everything hurt from both upper limbs, knees, and back. He was brought into the critical bay fully immobilized. On examination, young male was found lying supine in obvious painful distress with both upper limbs splinted, mucous membranes pink and moist. He's a known hypertensive, but his initial blood pressure was 103/49 millimeters of mercury with a pulse of 98 beats per minute. His respiratory rate was 20 breaths per minute with a normal temperature of 97. His oxygen saturation on room air was 94%. And his random glucose was 271 milligrams per deciliter. He was assessed and treated according to ATLS protocol. On examination, the patient had a GCS of 15/15. His chest wall was devoid of any bruising, and he didn't have any tenderness, but he had decreased air entry throughout. His abdomen also didn't have any bruising, but was obese, soft, and non-tender. His pulse was regular and palpable in both wrist and elbow. Heart sounds were heard and capillary refill was less than 3 seconds with no murmurs. Both upper limbs were splinted. The right the right lower limb was shortened and externally rotated. Initial assessment was a road traffic accident with obvious deformity of both upper limbs, rule out bilateral, radial, and ulnar fractures, rule out elbow dislocation, rule out right hip dislocation versus fracture, query whether he was a new type 2 diabetic, history of hypertension, and obesity. Investigations ordered were chest x-ray. Portable chest x-ray showed blunting of both costal and cardiophrenic angles with enlargement of the cardiac silhouette, obvious right posterior elbow dislocation, bilateral fracture of both ulna and radii. He had no fractures of the pelvis seen on x-ray. He had a right displaced proximal femur fracture, a right subtrochanteric fracture, a right tibial plateau fracture. ECG was normal. The patient's first complete blood count showed a white cell count of 24,000 with a predominance of neutrophil. He was anemic with a hemoglobin of 10.6. His chemistry profile showed a slightly elevated creatinine of 2. Initial management included analgesia with morphine, a liter of normal saline, Clexine at 1 milligram per kilogram. The upper limbs were splinted at the bedside. And further assessment, we needed a computed tomography scan of chest, abdomen, pelvis, and head. He was referred to both a general surgery team and surgical specials or orthopedics, but both surgical services required that he gets a computed tomography pan scan before admission. His ED journey. On day 1, we attempted to get a CT. It would have to be outsourced because our machine capacity, our weight capacity was 300. The first EMT transport were females. One of them had lower back issues, so we were not able to get a CT on the first day. On the second day, the males that presented, the trolley hydraulics were not functional, so we could not take him to CT on the second day. On the third day, the patient was still in the ED, not admitted, so I employed a senior security guard, senior house officer, Dr. M. Pinder, 4 EMTs from Doctor's Hospital, and 2 CT technicians. And we were able to get him to Doctor's Hospital next door for his CT. But guess what? We got him on the CT bed and we got a surprise. My patient did not fit. After waiting 3 days, my patient couldn't fit. So because he didn't have any shoulder injuries, I just squeezed, the shoulders together and we were able to fit him in. I just promised him some good pain medicine after. So, diagnosis, road traffic accident victim, polytrauma. He had a right displaced femur fracture, left ulnar shaft fracture, proximal ulnar dislocation, left distal radial fracture, right displaced proximal ulnar fracture and dislocation, right radial shaft fracture, right radial head fracture, right posterior shoulder dislocation, and the CT brain was normal, CTC spine was normal, but the CT chest showed right-sided pleural effusion, and he had rib fractures of both 8th and 11th rib. In addition to his polytrauma, he was also obese. The last time he checked his weight, he doesn't remember when, he showed it was more than 400 pounds. history of hypertension, and now impaired glucose. He was registered on May 29th, 2025 at 11:45 p.m. Finally, after the CT was done, he was admitted on May 31st, 2025 and taken to the ward. His first day to the operating room was June 10th, 2025 for open reduction internal fixation of the right femur fracture. His clinical course his second day to OT was July 1st, 2025 for incision and drainage of a right thigh abscess. The microbe isolated was a very stubborn Pseudomonas resistant to almost every antibiotic. The infectious disease team was consulted and appropriate antibiotics were commenced. The patient now also developed signs and symptoms of congestive cardiac failure on the ward, 2D echo done, ECG, X-ray repeated, cardiology consulted, and appropriate medications were commenced. The patient was discharged on August 5th, 2025, both upper limbs not yet repaired. The surgical team obviously could not operate if he still is infected with Pseudomonas. And the patient said that he felt that he'd been in hospital too long. He wanted some time home. Now, with a tibial plateau fracture not repaired, both limbs splinted, he still couldn't walk properly. So he's home. So today marks 120 days since the accident, and we still need more operating time. Trauma and obesity. The body mass index is a common screening tool, but it's not perfect. It's not a perfect measure of obesity. Other factors like waist circumference can also be used to assess obesity. But if the body mass index is calculated and it's greater than 30 or higher, it's considered obesity. The World Health Organization defines obesity as abnormal or excessive fat accumulation that presents a risk to health. The disease of obesity affects more than 1/3 of the US adult population. So adult ranges go from underweight, normal, overweight, obese, and extremely obese, with less than 18.5 being underweight, and obese 30 or greater. For children, a different set of percentiles are used for children between the ages of 2 to 20. There are certain changes in their body, and so obesity is calculated a different way. We have about 45 physicians in the accident emergency department. 40 of them took part in a small survey. And in the 40 that took part in the survey, at least 42% of them are overweight, 40 of them are obese, and only 17% are of normal weight. Obesity is a major public health concern in the Bahamas, with high prevalence rates amongst adults and children. 41% of adult women and 27% of adult men are living with obesity. Obesity prevalence is even higher than the regional average of 30% for women and 22% for men. So the Bahamian population, we are bigger than the rest of the Caribbean. And this time it's not something to be proud of. But there are multiple studies that indicate that the obesity is greater. There's greater prevalence in the female population. So from 1989 to 2019, the Bahamian National Report shows a consistent increase in the prevalence of obesity. There's a slight decrease between 2012 to 2019, but obesity remains high in women. There's a decrease in the obesity in men. On March 21st, 2025, our Minister of Energy and Transport, the Honorable JoBeth Colby Davis, released the road traffic accident statistics. Over 11,000 road traffic accidents in 2024, with 2,200 with minor victims with minor injuries or serious injuries. We had 66 fatalities. The Bahamas is ranking number 2 in the Latin American countries in fatalities per capita in road traffic accidents. Accident emergency registers about almost 1,300 patients for 2024 to 2025 with road traffic accidents. Globally, trauma and obesity, the news certainly isn't good for morbidity and mortality. Finkelstein et al. In 2007 reported that injury is likely in 15 to 48% of overweight patients. Hoffman also in 2022 released information from his studies to state that there's an increase in mortality in obese polytrauma patients. There's an increase in hospital mortality in obese patients that's 7 times greater in the people who are of normal weight. There's a 2-fold increase in urinary tract infections, bloodstream infections, and respiratory infections in patients who are obese and sustain traumatic injuries. The impact of obesity on assessment, it reduces accuracy. Physical findings can be less reliable in obese patients. Skin folds can obscure injuries and make it difficult to auscultate lungs. There's difficulty in imaging from accident emergency. There may be difficult beam penetration with point-of-care ultrasound. There's increased risk of complications. Obesity is linked to higher mortality in patients. There's delayed diagnosis, as we saw in our index case. Obesity significantly complicates the management of trauma patients, presenting challenges in airway management, ventilation, hemodynamic stability, and wound care. So, management strategies, advanced trauma protocols should be followed, focusing on the airway, breathing, circulation, and disability. Specialized equipment like bariatric beds, hoists, and other specialized equipment need for the patient care and transport, and early mobilization when appropriate. Venous thromboembolic prophylaxis is crucial. Some patients may need IVC filters, careful monitoring of vitals, and meticulous wound care is needed. The staff should be trained in the management of, well, average sized and overweight patients. Maybe a few studies were found to suggest that weight may improve survival, but not many studies support it. In summary, the physiologic abnormalities relating to obesity and metabolic syndrome can contribute worse to outcome following trauma, especially in the class 1, class 2, or 3 obesity. And there's higher risk of in-hospital mortality in patients living with class 3 obesity following trauma. My references. And to the accident emergency team, we obviously need to return to our bridge runs and walks. Thank you, everyone.
So good morning again. So the outline for this part of the presentation, I'll give a case report and do an overview of acute coronary syndrome via algorithm, and I'll dive into the guidelines, the 2025 ACS guidelines. So BM, a 64-year-old male, presented April 3rd, 2025 at about 10:15 in the morning via EMS. He was a hypertensive patient non-compliant with medications, complaining of central chest pain that started at about 1 hour prior while walking. He had radiation to the left arm, and he had grade 10 on 10 severity. Of note, he had diaphoresis, no history of palpitations, syncope, nausea, and/or vomiting, no shortness of breath, cough, fever, or chills. On examination, a middle-aged male, he was in painful distress. His blood pressure was elevated at 159 on 100, heart rate normal at 89, and respirations were 24 breaths per minute. His O2 saturation was 100% room air, and his random glucose was 167 milligrams per deciliter, temperature 95.9 degrees Fahrenheit. He was awake, alert, oriented ×3, GCS 15 on 15. Heart sounds heard, S1, S2, no 3, 4, no murmurs. His respiratory examination, he had bilateral vesicular breath sounds, no crepitations, no rhonchi. Abdomen soft, non-tender, no masses, no guarding, no rebound tenderness, bowel sounds heard. So he was assessed to rule out acute coronary syndrome. He subsequently went on to have a 12-lead ECG, as you can see here, and it was normal sinus rhythm. His rate was 86 beats per minute. He had right bundle branch block, and he had ST segment elevations in V2, V6, lead 1, AVL, the anterior lateral leads. His chest X-ray showed that he had prominent pulmonary vasculature, capitalization, bilateral interstitial and retrocardiac infiltrate, and he had atelactic bands in the left lower lung field. His CP angles were free bilaterally. Laboratory investigations were sent and returned. He had an elevation in his white cell count of 17,000. His platelet count was 89, and he had a creatinine of 1.4. Of note, cardiac enzymes were done. The first cardiac enzymes came back with a CPK of 195. His CKMB fraction was 2.37, and his high sensitivity troponin was 190.68. As you can see that they're all elevated. For ease of reference, the secondary set of cardiac enzymes is attached. There was no CPK in the system for the second time, but his CKMB was 13.37, and his high sensitivity troponin, as you can see here, is 1,951.85. His urinalysis he had was cloudy, and it had ketones in it with moderate leukocyte esterase that were small. So reassessment, he was reassessed as having a anterior lateral wall, ST segment elevation, MI, and also urinary tract infection. Aspirin 81 milligrams was given prior to arrival by EMS personnel, and GTN sublingual ×3 doses were also given. Morphine 10 milligrams was given, and clopidogrel 300 milligrams, Piostat given, pantoprazole 40 milligrams, Bravol 50 milligrams, Rocephin 1 gram IV, and Clexane 30 milligrams IV. The plan was to thrombolize the patient in consultation with the cardiologist, and referrals appropriate were made to internal medicine services and also critical care. Consent for thrombolysis was obtained. He had no absolute contraindications for thrombolysis, and alteplase was subsequently administered to the patient at 15 milligrams IV bolus, was then subsequently 50 milligrams over 30 minutes, and then 35 milligrams over the next 60 minutes. We got his second ECG post thrombolysis, and as you can see, we can better see the ST segment elevations in the anterior lateral lead. However, they seem to be going down. So post thrombolysis, patient looked ill, more ill than he looked initially, and he was in cardiopulmonary distress. His blood pressure was 130 on 74. He was tachycardic at 119. Tachypnic at 42 breaths per minute, and his temperature was 96.7. We were alerted via nursing that his O2 saturation had dipped to 88 to 90 via nasal cannula 3 liters, and he was subsequently switched to face mask at 5 liters per minute. A decision was made to subsequently give him non-rebreather at 15 liters per minute, and his O2 saturation came up to 92%. He was still awake, alert, oriented, times 3. Heart sounds 1 and 2 heard, no 3, 4, no murmurs. However, on his respiratory exam, he had bibasilar crepitations now, and his abdomen remained soft and unremarkable. His his chest x-ray that was obtained post-thrombolysis shows that he has bilateral perihilar opacities, obscuring cardiac silhouette and fluid in the horizontal fissure. His CP angles were minimally blunted. So we determined that he developed post-myocardial infarction complication in the purview of acute heart failure. Critical care recommended when they came down to review the patient that the patient be placed on high flow nasal cannula at 60 liters per minute flow rate, 95% FiO2. Diuresis was commenced and they advised to continue diuresing the patient. Input-output charting was done with Foley catheterization. Cardiology was updated and agreed with the management plan. ICU also informed that there were no beds available at the time, and so the patient was subsequently admitted to the ward. On the next morning, while the admission team was updating the family, BM went into cardiogenic shock. He subsequently became unresponsive and pulseless. ACLS was commenced. However, after a valiant effort, the patient was pronounced dead and the family informed. So with regards to acute coronary syndrome, it encompasses a spectrum. It encompasses unstable angina, non-segment ST segment elevation, and ST segment elevation MIs. And so the approach to these patients, you want to think in terms of ACS at initial assessment. You would want to get your ECG in a 10-minute time frame from the first medical contact, and you want to determine if there are any abnormalities present. You would want to determine the clinical context of the patient in terms of the history of the patient, and you want to determine the stability of the patient. You want to think in terms of invasive management for your ST segment elevation MI patients. You want to get them to primary PCI. If that's not available to you, you want to give them fibrinolysis. For the unstable and STEMI patients, you also want to think in terms of angiography plus or minus PCI. And for high-risk patients with non-ST elevation MIs, you want to think in terms of early angiography in less than 24 hours. That should be considered. You want to think in terms of thrombolytic therapy. You want to give your patients your antiplatelet medications, your aspirin, your P2Y12 inhibitors, and also your anticoagulant therapy in terms of your unfractionated heparin or your low molecular weight heparin as was given to this patient and others. You want to think in terms of revascularization based on the clinical status of your patients and comorbidities, PCI or coronary artery bypass grafting for these patients. And you want to aim for complete revascularization. Then you want to think in terms of your secondary prevention. You want to give your antithrombolytic therapy, your lipid-lowering medications. You want to discuss smoking cessation, cardiac rehabilitation, risk factor mitigation, management, and psychosocial management for these patients. So the incidence of chest pain and acute myocardial infarction and acute coronary syndrome for the last year, July 1st, 2024 through June 30th, 2025, Princess Margaret, as obtained from the Data Analysis and Statistical Unit, we can see the ICD codes for MIs, patients who would have presented to hospital. Angina pectoralis unspecified, we had about 9 patients. Anterior wall MIs, they document 5. Inferior wall MIs, 4. MIs unspecified, 26. Acute endocardial MIs, 71. Acute myocardial infarction unspecified, 26. And chest pain unspecified was 10 for a total of 151. So regarding these patients, the goal is to have reperfusion. You want to optimize outcomes for your STEMI patients with efficient execution of your STEMI care processes, but also on the seamless communication and coordination of care among the teams caring for these patients. So when patients present with symptomatology, either via EMS after calling 911 or via private car, you want to go down either of the algorithm lines to determine if EMS picks them up, you get your first medical contact and you get your you get your ECG within the first 10 minutes, and EMS determines if the patient goes to a PCI capable facility or a non-PCI capable facility. And we all know Princess Margaret is a non-PCI capable facility. So if you get to a PCI capable facility, some centers you can bypass the ED altogether and go straight to the cath lab. If you are taken to the non-PCI facility and you are able to get to a PCI facility within 120 minutes, that it would be wonderful. And then you would want to give fibrinolytic therapy. If you're not going to go there at all, you're still going to give you fibrinolytic therapy as the patient would have received in the emergency department. And then you want to determine if that was working or if the patient had improvement in symptomatology. But if that had failed, then you would still want to get the patient to PCI. Patient coming via private car, they go to a PCI facility. The cath lab is activated, right? And if it's a non-PCI facility, then you would want to ideally get the patients to a PCI capable facility. So the guidelines speak to us as to how we should manage these patients. And it was interesting to note that this year, 2025, the American College of Cardiology, the American Heart Association, also the American College of Emergency Physicians and the National Association of EMS physicians and our society just came up and updated the treatment of patients with acute coronary syndrome. And it was interesting to note that the Europeans also have their guidelines as well. And the most recent guidelines for them would have been in 2023. So the American Heart Association guidelines, this present guidelines will speak to the previous guidelines. And so those guidelines have been updated from, so the 2013, 14, 15, 2021 guidelines, it speaks to acute coronary syndrome. This is the most recent guidelines that speak to all of that. So what do they say? What does the guidelines say, right? So as we know, dural antiplatelet therapy is still in vogue, and it is still the choice for patients with acute coronary syndrome. So dural antiplatelet therapy with aspirin and an oral P2Y12 inhibitor is indicated for at least 12 months as a default strategy in patients with ACS who are not at high bleeding risk, right? And so you can use aspirin along with ticagrelor and prasugrel. They're preferred post-PCI. We know that they're more potent than clopidogrel. And they also suggest how you mitigate bleeding risk in these patients. They have several strategies that they recommend, whether you use a dual antiplatelet therapy with aspirin and ticagrelor, and then you would stop aspirin at about the 1 to 3 months period post-PCI, and then use a single antiplatelet therapy with ticagrelor monotherapy alone. Or you can do triple therapy with dual antiplatelet therapy and an oral anticoagulant. And also patients at risk for gastrointestinal bleeding, they also suggest that you use a proton pump inhibitor. You would want to discontinue aspirin at about 1 to 4 weeks post-PCI and then go on to a single antiplatelet therapy and oral anticoagulant with clopidogrel monotherapy and your oral anticoagulant. And then they talk about another strategy where you use aspirin and ticagrelor or prasugrel, and then you want to de-escalate, right? You de-escalate with aspirin and clopidogrel, because clopidogrel, like I would have said, is less potent. And then you have your strategies for high bleeding risk patients post-PCI, as seen on the slide. they talk about use of high intensity statin therapy is recommended for all patients with ACS, and the option is to initiate ezetimibe, right? So ezetimibe is a non-statin medication. And so what they determine is that atherosclerotic cardiovascular disease event rates are substantially higher in patients with recent ACS than those with chronic coronary disease, with 1-year rates of cardiovascular death, MI, and ischemic stroke estimated to be about 10 to 15% after an ACS hospitalization. So you want to initiate your high statin therapy. That's a class 1 recommendation. And then you want to consider adding ezetimibe. And then you want to repeat your lipid profile at 4 to 8 weeks post-discharge to see if there are any additional adjustments that need to be made, right? And then they go on and then they talk about patients already on maximally tolerated statin. And so they have an LDL of less than 55. You want to consider high intensity statin. If it's 55 to 69, you want to add a non-statin LDL lowering therapy. It's reasonable, and that's a class 2A recommendation. And if the LDL is greater than 70, you want to add your non-statin LDL lowering medication, and then you want to reassess your lipid profiles as well. And patients who can't tolerate statins or refuse to take statins, you can then consider to give the patients a non-statin medication, as there are others. The most impactful changes continue with complete revascularization is recommended in patients with STEMI and ST segment elevations, MI. And the choice for revascularization methods are coronary artery bypass grafting and multi-vessel PCI and STEMI patients with multi-vessel disease. And it should be based on the complexity of the coronary artery disease and the comorbidities. Patients with non-ST segment elevation ACS who are at immediate or high risk of ischemic events, an invasive approach with the intent to proceed to revascularization is recommended during hospitalization to reduce major adverse cardiovascular events. And so the unstable patient, the unstable and STEMI patients, as they present in cardiogenic shock, signs and symptoms of heart failure, including new and worsening mitral regurgitation, acute pulmonary edema, refractory angina, you want to do an immediate invasive strategy for revascularization with these patients. The high-risk patients and STEMI patients, we have risk stratification tools, the GRACE risk score greater than 140 or steeply rising troponin values, serial testing despite optimal medical therapy. You want to go ahead and do routine invasive revascularization strategies. And in that, you're going to use coronary angiography with a less than 24-hour period. You want to get them to have that done. Immediate risk STEMI patients with a GRACE risk score of 109 to 140. You want to do routine invasive revascularization, again, with coronary angiography before they leave hospital less than 72 hours. And then the low-risk patients, you can do routine invasive or selective invasive revascularization strategies in those patients. So there are two approaches in terms of PCI. You can use a radial approach, which is now recommended because it's easier to do, and the risk of bleeding is less than the femoral approach, and also the intracoronary imaging to guide your PCI for complex lesions. They recommend maximizing or optimizing the hemoglobin as best as possible, and so red blood cell transfusions to get your hemoglobin to at least 10 grams per deciliter may be reasonable in patients with ACS and acute or chronic anemia who are not actively bleeding. And after these things, you want to then focus on your discharge planning for these patients. So you want to discuss lifestyle modifications for these patients, reason for their hospitalization. You want to explain their medications with them, and talk about symptomatic management. We want to discuss return to daily routine and the psychosocial considerations and follow-up care. So in summary, the take-home points, the most salient points for this is dual antiplatelet therapy with aspirin and an oral P2Y12 inhibitor is indicated for at least 12 months as a default strategy in patients with ACS, not at high risk for bleeding. High sensitivity statin is recommended for all patients with ACS and with the option to initiate concurrent ezetimibe, and complete revascularization is recommended in patients with STEMI and NSTEMI. These are my references, and we will take questions.
Thank you so much to the Department of Emergency Medicine. You have presented 3 very timely cases, a lot of information, and I am sure that all of us would have benefited from the cases that you would have presented. So at this time, the floor is open for questions. And while everyone thinks of the questions and comment they would like to give, I would like to remind each of you to ensure that your name does reflect the name that you are registered in at the medical consult. Please ensure that we have your correct name, and also to complete the feedback link for this presentation. Do we have any questions for the Department of Accident and Emergency?
Sorry, I just have one question. This is Dr. Knowles for Dr. Delancey. Please, thank you, ladies, so much for the presentation. It really was informative. I know in your presentation you spoke about patients who got contrast with abdominal CTs having a higher risk of pneumonia and then acute respiratory distress syndrome. Is this a direct correlation, or was this just an incidental finding? And then if so, what's the link between contrast and respiratory illness?
Sorry, thank you for your question, Dr. Knowles. So that was just in one study that we saw where they actually, I don't think it was a direct causation. I think it was just correlation in that those patients had developed pneumonia after the oral contrast. And so they were correlating that that giving the oral contrast increased the risk once they were taken to surgery of them aspirating and developing an aspiration pneumonia. But I don't think it was a direct causation per se.
Thank you.
You're welcome.
Okay, thank you. Do we have any other questions, comments for the Department of Emergency Medicine? While you think, Dr. Joseph, in the presentation that you made regarding management in the obese patients, I know, unfortunately, that in our country, we continue to have patients with elevated BMI. How often do you find that you have an issue with being able to manage patient when they present to the emergency room?
Dr. Wallace, thank you for the question. It used to be that maybe it was once a year that we had a patient with a medical complaint presenting to the emergency room of that BMI. But the patient was registered on May 29th, and at least once a week since May 29th, before May 29th, and even of yesterday, we have a patient whose weight we don't know, but we just know that if we needed a computed tomography scan, it couldn't be done at PMH because it would the weight would exceed our machine and possibly the one at Oak Tree, and we would have to go to Doctor's Hospital. And so this is not just an issue for accident emergency to prepare for the patient who's overweight. I think as a public health concern, we need to make it a public health concern. For doctors, Dr. Delancey's patient and Dr. Davis's patient, if their family visited them in the emergency room, the first thing somebody would ask is, when can I feed Kenny? He eat in 3 days, right? So we have a special relationship with food, but my greater concern for this patient is that his hands don't work. He can't walk. So he's probably depressed and stressed out, the mental weight of all these injuries. He's going to be home eating more. So we have a great health concern with this overweight. So it's an everyday issue, Dr. Wallace-Bay.
Oh, that is so unfortunate. What is the capacity for the CT machines at doctors, if you know?
The Doctor's Hospital machine is greater than 600 for the weight, but I didn't anticipate circumference.
Wow. So this is definitely an example or a learning point for my primary medicine colleagues and the role that we play in helping such individuals.
Yes, and then Dr. Wallace, when the patient presents, because the weight is so great, they are a little embarrassed to get it on your scale. If you can screen them just privately and just say, it's okay. We just need to know, because patients that size, even if your scale had a weight capacity of greater than 500, the patient doesn't want to know that number. You can tell them, well, only I want to know that number then, right? So that we can have documentation, we can have something to work with, but it's definitely an issue. All disciplines need to work because this patient, this patient's BMI was so great, you end up missing injuries because you can't do things the normal way for a patient who's just normal weight or slightly overweight. And then we just have to be prepared on every level, because emotionally the patient is embarrassed, and certain words we use as a society, or this big man again, those things, we have to be a little more sensitive. But the orthopedic team did a good job. It's just that sepsis alone kept him from going back into the operating room for the surgeons to finish what they have to finish. But he just didn't want to stay anymore.
Okay, thank you, Dr. Joseph. There is a comment in the chat from Dr. Wells indicating that some of the trolleys calculate the patient's weight. So that would definitely be beneficial, especially in the emergency room setting. Do we have any other questions or comments for our presenters? Please note that the CME feedback link has been placed in the chat. Kindly complete the CME feedback link. We are doing our endeavor best to ensure that we get your CME credits to you in a timely fashion so that you are ready to submit your credits for the renewal of your licenses at the end of the year. Okay, I see no further questions or comments. So at this time, I would like to extend a special thank you to the Department of Emergency Medicine. You have brought some very important cases, very important topics. You have stimulated our minds. You have given us new knowledge. You have refreshed some of our knowledge, and we are thankful for that. So this ends another session of our CME, and I will see you at our next CME session, the second Wednesday of the month. Have a great day.